Good morning, everyone. Welcome to the CalAIM Educational Series Part 7. This is Aging with Options, training series on home and community-based programs. We've got a number of panelists. Up first is Melissa Templeton. She's the Director of Clinical Services with Star Nursing, and she will be giving a presentation on the Assisted Living Waiver Overview. Melissa?
Hey, good morning, everybody. My name is Melissa from Star Nursing. Thank you so much for being here today. So, I'm going to go ahead and get us started off on the Medi-Cal Assisted Living Waiver Program. Star Nursing is a care coordination agency, so we function as one of many CCAs. We're like the eyes and ears for the state. Um, um, So sorry about that. And so we are a continuing care agency. So what our role is right now, the current way to get on the Medi-Cal Assisted Living Waiver Program is to go on a wait list, regardless of skilled nursing, APS, things like that. So I'm going to go over timelines for that and give you a little bit more information. So the Medi-Cal Assisted Living Waiver Program is developed by Department of Healthcare Services to make assisted living affordable for individuals that are in need. And then next slide, please. Perfect. So a little bit more about the assisted living waiver program and the advantages of it. It's less restrictive and less expensive than nursing home care. Assisted living is bridging that gap between somebody living in maybe an independent living or somebody living in at home, somebody that is in assisted living and is running out of funds and cannot live on their own. So there's a lot of different situations, but we're bridging that gap, trying to prevent somebody from going to a nursing home, or somebody that no longer needs skilled nursing level care can go into an assisted living. So we're really bridging that gap. Um, Next slide, please. Okay, so let's get into the eligibility requirements and the disqualifying criteria. So you have to have a full scope Medi-Cal with zero share of costs before enrollment. And I'm going to go into a little bit what can happen if you do have a share of costs. So per Medi-Cal income limits for no share of costs, their income must not exceed 1800. If income exceeds that, um, if income exceeds that, once they move into an assisted living, since they're now paying into their care, we can get that share of cost removed. And so don't get too caught up on that. CCAs are responsible for helping assist remove that share of cost. If it needs a special budget or to prove that they are paying so much into their care. We usually send that out to an insurance expert that understands share costs really well. But normally, any CCAs should be responsible for getting those share of costs removed. So we can take a member that has a share of cost, um, and we can start the process for them. And um, we can start that process for them. We can get them on the wait list. We can get them placed in assisted living, and then we'll work on getting that share of cost removed once they're moved in. We have 6 months from the date we submit the assessment to get that share of cost removed. So Star Nursing and CCAs will take care of that. So you have to be for this particular program over the age of 21, and to qualify for an assisted living, you have to be able to have you need some kind of care level need, whether it's mobility, bathing, bathroom, dressing, grooming, eating, and taking medications. There's so many other ADLs, right? Behaviors, unable to manage day-to-day activities. Those are just some that come to mind. And then your needs have to be safely met in a residential care facility, right? These are licensed RCFEs, and there's only so much care that they can give. And so that's when I'm going to talk about the disqualifying criteria. Um, so I'll go into the disqualifying criteria in just a moment. Members will need income, so they have to pay a room and board fee. And then CCAs, once they do move in, so maybe they can't pay that standard SSI rate for room and board, um, right when they move in. Once they move into an assisted living, we'll help them get that cost of living increase. That should be a CCA's responsibility to assist with that. Um, so you can't be enrolled in other waiver programs, right? No double dipping. So MediConnect, Scan, and PACE programs, right? Other waiver programs also disqualify them for meeting this. Um, they can disenroll if this is a better fit for them. You know, again, remember members' rights to choose what programs they're in. But let's get into the disqualifying criteria. So they have to have sufficient income, or we can be working on getting them income. Or So this is kind of the range right now that we're looking at for 2025, 13.24 and 82 cents, to 13.44 and 82 cents. And you guys are going to see how we determine their room and board fee in just a moment. But basic things. So what if you guys are going to refer somebody for this, think about um, conditions that required a skilled nurse to manage, right? So stage three wounds or and above, or wound vacs, right? Usually need a skilled nurse to manage that. Not all assisted livings have 24/7 skilled nurses available. So we will, as at the CCA level, before we even submit to Department of Healthcare Services an assessment, our RNs will go through, assess the member, ensure that their needs can be safely met in assisted living. Um, and then, of course, NG tubes, IV, TPNs, restraints. And then, if they are able to manage their own insulin, we can get them processed, no problem, but they have to be able to manage that insulin. So that means they have to be able to understand, hey, if my insulin if my blood sugars are above this, I need to give this much insulin. So they really have to they can't just blindly self-inject, right? Their insulin. They have to know why they're taking it, um, things like that. And our nurses do assess that before we submit an assessment to DHCS. So they have to be able to operate their CPAP and BiPAP on their own. So if you guys are ever thinking about referring somebody to the Medical Assisted Living Waiver Program, think if they have a skilled nursing need, then a skilled nurse to manage it, then we're probably going to disqualify them. But still reach out to your CCAs, and case by case talk about, this is what my member is dealing with. So, always reach out. Usually, anybody can say, yeah, we could probably get them placed or not. So just reach out to the CCAs. If you think that they have disqualifying criteria. But remember, a skilled nurse doesn't need to be giving any caregivers can give baths, dressing, grooming. They have med techs that can administer medications orally, things like that. So just kind of think of, when you think about disqualifying, is it a skilled nurse need to manage that? Next slide, please. Okay, so how does the process work? So say so this is kind of a after a qualifying stay in a skilled nursing, post-acute, long-term care hospital. So there's multiple ways to get on it, but right now we're going to focus on what happens if you're in a skilled nursing. Um, so same thing is, you have to have income, you have to have needs that are safely met in a residential care facility, and we can complete a STAR nursing on their behalf as a CCA. So how it currently works, we submit a wait list to Department of Healthcare Services, and then once that wait list is, then the state will release that name off the wait list to the CCAs. Once we get that wait list, our nurses will go out and do an assessment to determine if they are appropriate for assisted living and appropriate for the program. Once that is done, um, once the assessment is submitted by our nurses, we have 6 months to place this member in an assisted living that's ALW waiver approved. Once we do placement, we are the care coordination agency, the continuing with that. So our RNs will go monthly out to see them every month, making sure that they are, we're kind of advocating as well, like, is care getting done correctly? Are members happy? Do we need to make a better care plan? So we're really involved in that assisted living that assisted living for that member. So sometimes we have care conferences, families are happy, or there's we play such a good role. We're an extra layer for the assisted living and for our member to help coordinate that care. So that's the current function. We're gonna go into wait times as in just a moment. And so we'll go over that. So some of the paperwork that is needed is, if they're in a skilled nursing, we need that admission phase sheet, good history and physical medication list, assessment, and there are some consent forms that need to be signed. There's an amenity waiver and a freedom of choice waiver form that needs to be signed, and we also require a 602 report. That is essential in placement. That is a requirement for Title 22 that assisted livings have those 602s on files. And it really does help gather information about that member. Next slide, please. Okay, and then just a little bit more about RCFEs and ARFs. What do they do once a member goes into an assisted living? What kind of care is being given? So, they're, usually that call light, they have a call light to summon assistance. Um, some have private and semi-private rooms. Private rooms are not guaranteed. Um, they provide medication assistance with their med techs, intermittent skilled nursing services as required by resident. So some facilities do have skilled nurses on an LVN on staff. Some provide very rare encounter Costa, but some facilities do have nurses that are able to administer that insulin and things like that. But it's pretty rare. And they are governed by Title 22. So assisted living does not uh, offer that 24/7 skilled nursing care, but they do have caregivers available and med techs available 24/7. So they assist personal care, known as activities of daily living. There's washing, drying, folding laundry, housekeeping, providing 3 meals a day and snacks. They have to follow those diet orders if required. Assistance with coordinating transportation, providing daily recreation activities, and providing social services as needed. Go ahead. Next slide, please. Okay, so this is what everybody wants to know now. So what is the current estimate wait time? So skilled nursings are they have to have a 60-day qualifying stay to go on the skilled nursing wait list for this program. It's taking approximately 7 to 9 months. So we submit that wait list. And it's taking 7 to 9 months for them to be released. Once they're released, we are going to go ahead. Once they're released from the wait list to the CCAs, we're going to start reaching out to those skilled nursings. Some of these guys may have gone home already, and we're trying to making sure we have all the paperwork, and our nurses are going to start that assessment. And then once we get that off the wait list, we have 60 days to submit an assessment. So if you're putting people on the wait list, make sure that the accurate contact phone number is on the wait list form. It's very important. Sometimes I even add a little bit more information if there's so you can add the member's number, but maybe there's a caregiver that's really involved. Add 2 numbers. I know there's not a space on the wait list for that, but just add it anywhere because we only have 60 days once they come off the wait list to submit an RN assessment. And once we submit that assessment, we can start placement. Okay. Um, so that's the wait time right now is 7 to 9 months from SNF. If they're APS and there's an open active case, it's taking 6 to 7 months for them to come off the wait list. And ombudsman's letter is taking 1 to 2 months. Um, and if they're at home in the community, so they're currently at home or maybe they're in an assisted living and they're running out of money, it's taking 2 to 3 years for them to come off this. This is just, current wait times. I wish they were a lot shorter, especially for those in the community. I highly recommend. So maybe you have somebody that at the time you submitted a wait list that could safely reside at their home or with minimal care. But now as your member is, declining, and maybe it is an I'm sure everybody knows what an adult protective service situation is happening. You can go ahead and reach out to APS and they will determine if they will open a case. So something to kind of keep in mind if for this 2 to 3 year wait, if we're running into that someone needs it now, they're running, they're escaping their home, police are bringing them back home, maybe their dementia has gotten worse. That would be time to do an APS case and get that speeded up a little bit for them. And this is just the new kind of process in 2025. It used to be a lot quicker. I know everybody's thinking like, "Oh, I've had members get through the wait list quicker than that." Well, times have changed. In 2025, we have to submit everybody to the wait list. So we used to be able to take a skilled nursing member at a 60-day qualifying stay and submit that assessment immediately. We didn't have to wait for that wait list, but now we do have to wait for that wait list to be released, and we do have to submit a wait list. So currently room and board rates. So don't get caught up on unlicensed room and boards when you hear it. This is just a verbiage thing. Um, this is a licensed facility, but this is the room and board rates that they have to pay. And it's based on their income. So if they make less than 15.99 and 7 cents, their cost will be their cost will be 14.20 and 7 cents, right? And then income greater than that 15.99 greater, it's just a $20 increase and it's 14.40 and 7 cents. Um, so that's kind of the room and board rates right now. Again, if they come into an assisted living without income, so families can supplement if they're able to, and then we could start, hopefully getting them some kind of income. If families willing to work with us and things like that, we'll usually take it and work with the facility and say, hey, we're working on this income. Family is able to pay the standard until we get them income. Okay. And then if it's below this, if it's below the 14.20, and they have SSI, we can get that cost of living increase. Okay. So, if they call you think, okay, this person would be great, but they don't have income or they don't have enough, just talk to your CCAs, and they can walk you through that process. And we will actually, STAR Nursing actually has a team that will actually do this once somebody moves in and they don't have enough income. So, and usually facilities are okay with it. Just being open and honest and transparent with facilities to get them moved in and say, hey, it'll get increased once they move in. Next slide, please. Okay, so residential habilitation, you're gonna hear it known as RH. So once somebody's enrolled in ALW, um, and it doesn't matter what tier level they are. So a tier level is is determined by the RNs, and I'm gonna go over tier levels in just a moment. But not a lot of people know about RH, so it's the residential habilitation program. So once somebody's enrolled, right, their share of cost is removed, their county changes, and now in the waiver county, now we go ahead and we say, how's it going? So we're going in every month with our RNs, and we're saying, how's it going? Well, Peggy Sue, she's having a lot of behaviors. She's having a really hard time adjusting. And then our nurses will say, let's go ahead and assess them for RH. We'll explain it to that, and it's billed at 15 minutes. It's $6 and 75 cents per 15 minutes. Um, and some of these guys need eight a day. So it's giving assisted livings more income to hire more staff. That's the goal. More staff to be able to um, uh, help manage this member. And next slide, I think I'm almost done. I'm sorry, Chris. I know I'm past my 15. And then these are the chair rates, and these are determined by our RNs via the DHCS assessment tool. So here's a list of CCAs and other AL and all the ALW approved assisted livings. So these are just some rates that are given per day. All right, and that's it. Thank you guys all so much for having me today, and I appreciate it.
All right, thank you, Melissa. Up next, we have home and community-based alternatives, the waiver overview. This will be done by Christopher Brady, the director of the HCBA waiver program at the Center for Elders Independence. Christopher, I'll let you take it over.
Thanks, Thanks, Chris. I am here to talk about the home and community-based alternatives waiver. Before I get into the HCBA waiver, I just want to talk about a common misconception. Chris, it's not letting me advance the slides. Oh, here we go. So there are home and community-based services waivers that generally try to keep Medi-Cal recipients living in their homes as opposed to having to go to a facility. Those are HCBS waivers. I'm here to talk to you about the HCBA waiver, the home and community-based alternatives waiver, which is one of the HCBS waivers. And I think we're going to hear, so the assisted living waiver we just heard about is an HCBS waiver. And we're going to hear later from Choice and Aging about MSSP, which is an HCBS waiver. But I'm going to talk to you about the HCBA waiver today. Thanks. Sorry, Chris, can you go ahead? The next slide. The HCBA waiver is to provide care management and care services for people who are at risk of moving to a nursing home or who are in a nursing facility and want to discharge back to the community. We serve Medi-Cal beneficiaries who are typically living with a disability and are SNF eligible. We provide services through a team made up of a registered nurse and a social worker and a patient care navigator. There are no services available for someone in a skilled nursing facility, but once they discharge home, and that can be a house, an apartment, whatever their choice is, then we begin providing services then. We do try to help people discharge, of course, when they're applying for the waiver. So, and the Center for Elders Independence, we are the waiver agency for all of Alameda and all of Contra Costa County. Chris, go ahead. We serve almost 750 people in Alameda and Contra Costa County. The HCBA waiver is open to people of all ages, so we do have infants on the program, and I believe we have 5 or 6 people over 100 years old right now. It's typically people living with pretty complex illness or multiple illnesses, usually mobility dependent, sometimes with tube feeding assistance. They may be on oxygen. It's often people with head injury and spinal trauma as a result of an accident, profound developmental delays, which they've had since birth, and also people in the later stages of neurodegenerative diseases, like Parkinson's, ALS, MS. Next slide, please. In addition to case management, under the HCBA waiver, participants may be eligible to receive waiver personal care services, which I'll go into in a little more detail on the next slide. If Some participants may be eligible for private duty nursing, in which we work with home health agencies to provide like 8 hours of nursing care in the home. The home and family respite is if the family is going out of town for a short time and the family have a primary care providers, we can provide a temporary surge in services to help the participant remain safely at home. And then there's a small amount of funds for environmental accessibility adaptation. It's capped at $5,000. That's a lifetime amount. So we're not making bathrooms wheelchair accessible, but we might be providing wheelchair ramps outside to get into the home, or doorway widening, things like that. So, next slide, please. So as I mentioned, the waiver personal care services are our most commonly used benefit under the HCBA waiver. Waiver personal care services allow you to hire someone to come into the home and provide assistance with activities of daily living, or IADLs. The WPCS hours, as it says, are meant to supplement IHSS hours. So whereas IHSS hours cap out at 283 hours a month, WPCS can supplement those and get someone up to 720 hours a month, or 24 hours a day, if they qualify. Most people on the waiver don't qualify for 24 hours of services, but we are able to get them up over that 8 to 9 hours a day that IHSS can provide if they qualify. So, waiver applicants do not have to have IHSS in place before they apply for the waiver, but they will need IHSS in place by the time they're enrolled in order to start receiving waiver personal care services. So, next slide, please. So who is eligible for the waiver? You must have full scope Medi-Cal without a share of cost. Participants are at risk of having to move to a skilled nursing facility, or they're currently in a skilled nursing facility and have been there for 60 days and want to discharge to the community. As I said, it's open to people of all ages. You must have a primary care physician. The primary care physician does not need to refer you to the HCBA waiver, but during the intake process for the HCBA waiver, we will create a treatment plan, and that treatment plan gets signed by the participant, and it needs to be signed by a doctor in order to get somebody enrolled. So, but if you're already working with the primary care physician, you will continue to keep that when you're on the HCBA waiver. For those of you who are familiar with our PACE program, the PACE program requires you switch to one of the PACE program physicians, but under HCBA, you keep your own. And then a couple notes about the AIM services. You cannot receive enhanced care management while enrolled in the waiver, but you can receive enhanced care management while applying to HCBA. And again, IHSS is not required to apply, but in order to receive certain HCBA benefits, you'll want to be enrolled in IHSS. So now the bad news, we currently have a waiting list of over 1 year. We're currently working on applications for applications that were received in the first quarter of 2023. Applications have to be processed in the order they were received. It does not matter if the doctor writes a note or it's an APS case. It's strictly the order they were received. with two exceptions. Applicants who are under 21 years old move to the top of the wait list, and applicants who have been in a skilled nursing facility for over 60 days move to the top of the wait list. Here's where you can find an application. You can get it on our website. You can call or email us, and we have a team that covers those contact points, so we'll typically get back to you the same day. The application is 4 pages long. It's pretty quick to fill out. It'll take you maybe 5 to 10 minutes, and you'll probably spend, applicants typically will probably spend half that time just looking up their Medi-Cal number to include on the application. The intake process, when someone comes off the waiting list, can take up to 90 days. Waiver benefits are not backdated during that process. So it's not until someone is enrolled that they start receiving waiver benefits. I'm going to get into just the weeds a little bit. Some of you may have heard about waiver benefits being retroactively applied. There's a point in the intake process in which we send all of the application materials to DHCS in Sacramento, and then they can take a couple of weeks or even a couple of months to approve an application. Right now, it's taking about 21 days. During that time when DHCS is approving the application, the waiver benefits can be backdated to the date that the packet was submitted to DHCS. You don't need to remember any of that, but if you hear of waiver benefits being retroactively applied, that's what it is. It's not applied back to the application date. And it really helps if you do include a med list and some doctor's records in with the application. So again, this HCBA waiver program is completely separate from PACE. You cannot be enrolled in PACE and the HCBA waiver. I should also mention that the HCBS waivers are all unique. So if you're enrolled in HCBA, you cannot be enrolled in the assisted living waiver or the regional centers developmental disabilities waiver or the MSSP program. So, but we do serve recipients of all ages. We cover both counties. And remember that last letter makes a difference. HCBA is one of the HCBS waivers. Thank you. If you want to throw questions in the chat, I'll look at them. Chris, I finally realized if I hit the next button on my keyboard, it advances the slides. So thanks for your help on that.
Yeah, no worries. Thank you, Christopher, for your presentation. So up next, we have Community-Based Adult Services, CBAS, and Multi-Purpose Senior Services Program, MSSP overview. This will be completed by, or held by Dr. Barbara Porter. She's the site director at Choice and Aging, Debbie Toth, who's the president and CEO at Choice and Aging, and Holly Tillman, the vice president of operations at Choice and Aging. And we'll turn it over to the three of you.
Great. Thank you so much, Chris. I'm Holly Tillman. I'm the Vice President of Operations with Choice and Aging. And with me today, as Chris mentioned, is our President and CEO, Debbie Toth, and Dr. Barb Porter, who runs the MSSP program here in Contra Costa County. As you can see on the screen, this is a quote that we like by Winston Churchill. We make a living by what we get, but we make a life by what we give. And so if you can remember that as we're going through our program today. I will discuss the agenda, which I'm trying to use the advanced slide option, and that is not working as smoothly. There we go. Thank you. So today we will be discussing, Debbie will walk you through who we are at Choice and Aging, as well as our adult day healthcare and community-based adult services, or CBAS. And then you'll see a snapshot of 2 CBAS centers. And then Dr. Porter will walk you through MSSP here in Contra Costa, and then we will provide our contact information. And with that, I will turn it over to Debbie.
Great. Thank you, Holly. So I'm going to speed through a little bit, hoping to keep us on time for our last presenter. So I share this slide to show you our history. We've been around since 1949. We started as a polio rehab facility, but from 1949 through to today, our agency's goal is to keep people out of skilled nursing facilities. So we have expertise in disability and we have expertise in aging. We really started focusing on the aging population in 1982 when we became the 16th licensed adult day health facility. It's important to understand, you hear the term CBAS, community-based adult services. That is the Medi-Cal benefit of adult day healthcare. Adult day healthcare is a licensing designation by the California Department of Public Health, and CBAS is the Medi-Cal certification to provide that service to Medi-Cal recipients. So you'll hear CBAS or ADHC maybe come out of my mouth. They are one and the same for the purposes of this presentation. We added on multicultural programs and became experts in Russian language populations and Farsi and Dari speaking populations. We also had the first Alzheimer's daycare resource center that we piloted here. So we have a lot of deep expertise in mid to late stage Alzheimer's and dementia and in caregiver support around those. We brought in complex case management, which Dr. Porter is going to talk to you about in just a little bit, in 2008. And so we have quite a bit of experience with this frail older adult population. We also added a program called California Community Transitions, where we transition people out of skilled nursing back into community. And then we added an intergenerational preschool because we were bored. And you can see the littles running around in my backyard behind me. That's the temporary playground right now. So anyway, that's who we are as an organization. We've also expanded and provide MSSP in Solano and Napa, as well as CCT, the California Community Transitions, in Solano and Sacramento. So what is adult day healthcare or community-based adult services? It was something developed in the 1970s to avoid some really bad things that were happening in skilled nursing facilities. Much like we saw during the pandemic, we saw some of these really bad things that were happening in skilled nursing facilities. That was happening in the 70s and being highlighted on ABC, CBS, and NBC. So I don't know who the audience is here, but you may not have been around then. We only had 3 major stations and they were all running the shows. And so the California government felt really compelled to do something better. And so they said, what if we take the staff from a skilled nursing facility and we put them in a daytime program that looks and feels like a senior center? And that way they can get the medical and social services they need during the day, but go home and sleep in their own beds at night and not live in institutions where most people don't want to be anyway. I mean, some people absolutely have to be there, but if you don't have to be there, why would you be, right? It's more expensive to the taxpayer. It's less person-centered to you. So we have the same staffing. You can see the staffing outlined there as a skilled nursing facility has. And what does the typical day look like? So we provide transportation to and from the program. There are a variety of different transportation solutions we have, but if the caregiver can't take them, we make sure they get here and get home. We provide morning refreshments. We do therapeutic activities all day long. It may be music therapy. It may be horticultural therapy. It may be pet therapy. It could be a discussion group. We have medically tailored meals that are locally sourced, so we're using healthy food. And then we have interventions that are happening throughout the day from our physical therapist, from our nurse, but really we're trying to do things in a congregate setting so that people are creating community and they actually do that. And I don't know if we can play that video or not. I don't have the button to play the video, Chris. I don't know if you do. It's really short.
Sorry, it doesn't look like it. We'll see if this can get preserved when we post the slides, though.
Okay. All right. So then we'll just advance to the next one. So I wanted to give you this snapshot so that you could see we have 2 adult day health centers, or CBAS centers. One is in Pleasant Hill, one is in Antioch. And if you ever want to see the impact of social determinants of health, you can look at the 2 different populations we're serving in these 2 different geographic regions. So these numbers are, I apologize, I didn't have a chance to update them to today, but this is like right before we went into the pandemic. This was the profile of our Mount Diablo Center in Pleasant Hill versus our Bedford Center participants in East Contra Costa County. So the average age you can see is much younger at the Bedford Center. Both have extremely high needs. If you are coming to CBAS, that means that the health plan has said that you are at quote unquote imminent risk of skilled nursing placement, hospitalization, or emergency department utilization. That is the Title 22 standard. We keep hearing about Title 22, and that's where our regulations live. So that's what we're doing. So we We provide the program in Contra Costa. We're the only provider of adult day health services that are CBAS here. And I do want to say that enrollment can take quite a while. We have to go through a doctor's history and physical, a clear TB screening, a home visit before we can even start the enrollment process. Then we have 2 more days of assessment. And then there's a process to put together the care plan. So it can take anywhere from 6 weeks to 3 months from start to finish to enroll in the program. And I'll pass it off to Dr. Barbara Porter now to talk about MSSP.
Thanks, Deb. I appreciate that. Well done, my friend.
Thank you.
I'm going to mess up the slides a little bit here. Well, thank you very much for allowing us the opportunity to present the MSSP program. There's been a lot of confusion over the years on what, oh, great.
Wow.
It's in the energy of our organization. I don't know. We're almost
We'll get there,
there.
Barb. You could just present. You're fine.
That's okay. Some people would call and say, what is the Mississippi program? And I said, no, it's called the Multipurpose Senior Service Program. While we're administered by the California Department of Aging, we're part of what you may have heard thrown around the 1915 C waiver. That's part of the Federal Social Securities Act. And what that means is that they've allowed states to waive some Medicaid requirements to ensure that people who are potentially could be institutionalized the opportunity to be staying at home and have other options at a much cheaper level than going into a skilled nursing facility. Choice in Aging, as Debbie shared with you, is our home nonprofit organization, of which we have 2 MSSP programs, the one in Napa Solano and I'm the one in Contra Costa. Just by way of passing, there are 58 counties in the state of California. There are 38 MSSP sites. There's only one MSSP site per county. And last year we've been awarded that we are now a statewide population. So I expect some of those other counties to start filling in with MSSP opportunities for people. Thank you. As Deb just said, I don't need to reiterate, but our main goal is keeping people out of skilled nursing. Whenever I've done presentations, I said, raise your hand if you think you'd like to spend the last month or the last year of your life in a skilled nursing facility. And it's funny, nobody raises their hand. So our main goal is to keep people out of skilled nursing for as long as possible so that they can maintain their dignity and their sense of well-being. And if you talk to seniors, one of the things that bother them the most is like they don't want to become a burden to their family. And the last place they want to be is in a skilled nursing facility. So one of the things that MSSP can do, we're a cost-effective choice for people. I'm going to try and click this button. So who can get into MSSP? It used to be 65 years and older, and just recently in the last month or so, the state has lowered that age to people who are 60 and older. These are people everybody in our program has many, many hours of IHSS. They have multiple, anywhere from 10 to 20 medications. I say we have the frailest of the frail and the most complex medical needs. And if it wasn't for MSSP, they would end up in a skilled nursing facility. And our goal is to keep them at home. It says enrolled with zero share of cost. There's a little wiggle room on that. One of the things is sometimes people may have a couple $100 over what Medicaid or Medi-Cal in California would say is acceptable. If they buy in a vision rider or a hearing rider or something, that brings down the share of cost, so we can do that. So what is our role in terms of working with the people? What do we do in MSSP? One of the unique factors of this program, we're a long-term and in the word I'm looking for is intense case management program facilitated by a registered nurse and a social worker. Most of our social workers are MSWs. I say MSW for our business doesn't stand for masters in social work. It stands for masters in scrounging whatever, because they've become the resource people who have looked for what can we do to help improve the lives of our people to keep them at home independently. So we work with the family and caregivers when they go into the home. During COVID, we weren't doing home visits. Now we're required to be in the home to do all the psychosocial assessments, all the nursing assessments initially. The team gets together and writes up an intense care plan that covers medical needs, holistic needs, safety needs. One of the most important things is that we can do things that regular Medi-Cal does not pay for. I'm sure you've heard of the emergency response button. We get calls all the time saying, "Can you help? I've fallen and I can't get up" story. One of the things we evaluate for safety issues, and we can provide the emergency response button. I had a particular family where he was no longer able to manage without being in a wheelchair, but he couldn't get into his bathroom. The doors were too small, so we had to tear the doors down and we could pay for the bathroom. One of the things that we do is respite care for people when they don't have enough. I mean, families get burned out. I think we all know that. So one of the main issues is we want to make sure that they have an opportunity to recharge, because caregivers are the most important people in taking care of the people that we care for. So we also want to take care of them. Um, are we cheaper? Oh, you better believe it, we're cheaper. It's even a greater percentage than that. One of the things I figured out just this morning, it costs $6,000 a day to keep somebody in MSSP, compared to, I'm not great on math,
A
but
year.
compared to
$6,000 a year, not
a
a
year.
day.
I mean, I'm sorry. Thanks for the correction, Deb. A
No
year, compared to in Contra Costa anywhere from $80,000 to $100,000 a year. So I may not be great at math, but it's like the difference between 6,000 and 100,000. We do save the state a lot of money in dealing with that. Here's where I want to get stress. This has been a big bugaboo of late. ECM and MSSP can't live in the same house together. They're wonderful programs, but they won't get along if they live in the same house. If somebody's in ECM, they can't be in MSSP, and vice versa. One of the reasons for that is the way the structure has been set up, and I know it's in the ECM. So I look at ECM as being a preliminary starting point for people that didn't get into MSSP right away. Speaking of getting into MSSP, we have no, compared to other programs, we have no wait list. If you've got people that you think need enhanced an intense case management, we're ready to take them in, and the turnaround time is anywhere from a week to 2 weeks to get our nurse and social worker to go out and visit them. So we're ready and open for business and take care of them. But the main thing is we have a nurse and a social worker team that works coordinatively in setting up a care plan. Our social workers go into the home every 3 months. They talk to the person and their family and their caregivers every month. We have 2 sites. We have, this is how you can reach us. If you go to our Choice in Aging website, there's a referral form, and it's HIPAA secure. So once we get it, we're ready to turn it over and get it to our nurse, and they'll call the family and we'll start the process right away. So anyway, I've been doing this for 11 years. Look forward to doing it for more. And we know we save lives, and that's what we're all about. Thank you so much.
Chris, I think we're going to give the other presenters some time to present, and the slides, since they all have availability to see them, they can take a look at their leisure.
All right, will do.
Thank you.
Kind of pause here just so people can really see them in preparation for the final slide deck posting. And just as a reminder, this whole presentation will be recorded. All the slide decks, the recording, the Q&A will all eventually be posted on the CCHP CalAIM website, so anyone can review this at their leisure in the future.
Thank you.
And some additional resources for Choice in Aging, and a whole lot of contact information. So I guess hit that screen capture button right now before we move on. All right, so up next we have in-home supportive services, the IHSS overview. This will be presented by Alice Dietrich, the IHSS division manager. Alice, it's all yours.
Good morning. As Chris just said, I'm Alice Dietrich. I've been the IHSS division manager since the end of September 2024. In a nutshell, in-home supportive services, or IHSS, is a program that helps aged, blind, and long-term disabled people live in their homes with dignity rather than relying on institutionalized care for their basic needs. Recipients of IHSS can hire a provider of their choice to help them with personal care services like dressing, bathing, toileting, feeding, paramedical services like injections, wound care, and colostomy and catheter care. IHSS can also provide wages for a provider for protective supervision in the home for people with mental health conditions or impairments that put them at risk for injury. To qualify for IHSS, someone must be approved for Medi-Cal, have a healthcare certification, and have a needs assessment done by a social worker who visits them in their home. Once approved for services, clients then have a yearly reassessment of their needs. Currently, over 17,000 people in Contra Costa County receive IHSS, which is an increase of over 20% in the last 3 years. We currently have 45 full-time social workers. See, I'm trying to advance the slide here. Let's see if I can. There we go. So we have a video clip here with a link that you can copy from the PowerPoint if you'd like to provide that to anybody. It does provide a summary of IHSS services for applicants.
Yeah, sorry, since obviously we can't show this right now, but when this slide deck is posted, that link will be available for everyone.
Sure.
Off the slide deck.
So the link is available there. Let's see if I can, next slide, there we go. So just to recap some of the salient points from the video, to be eligible for IHSS, a recipient must be 65 or older, be blind or long-term disabled. They must also meet the following conditions. Physically reside in the United States, be a California resident, have current Medi-Cal eligibility determination and be eligible for services, live in their own home or another dwelling in which they choose to reside. So acute care hospitals, skilled nursing facilities, and intermediate care facilities are not eligible for IHSS. And the applicant must complete a health certification form. So IHSS only pays for services that have been authorized by a social worker. So when authorizing hours for help, the social worker will talk with the applicant or recipient and consider things that the recipient needs assistance with and what things the applicant or recipient is able to do safely on their own without help. So the goal of IHSS is to provide support for the recipient to remain as independent as possible, but to allow the recipient to perform the tasks that they're able to safely do on their own. So a referral is a contact about the IHSS program received by a third party who doesn't have the legal authority to make decisions on behalf of the potential applicant. So that would be contact from somebody like a healthcare professional, a neighbor, a friend, a religious affiliate who believes that somebody might benefit from IHSS services. So for a referral, the county records the contact as a referral until the county has contacted the individual or their authorized representative to determine whether the individual referred is interested in applying for IHSS services. So the referral would precede an application. Anybody can apply for IHSS at any time, and they can also have somebody or authorized representative make application for them. So to apply, there are phone numbers that somebody can call without a need to come into the office. We have listed the 925-229-8434 number, and we should also have included the 800 number, which is 800-510-2020. So that number is staffed during business hours, Monday through Friday, but anybody can leave a message 24/7 outside of that time frame and will be contacted by a social work staff in order to schedule a home visit. So that number also goes to our INA, our Information and Assistance Helpline. So they are social workers who are really referral ninjas. They have all sorts of information about different programming in addition to IHSS as well. So that's really a one-stop shop for application. So to apply, someone can make application over the phone or in writing by submitting an application for social services. The following data is necessary for the application to be complete. So the application must include someone's name, social security number, date of birth, their preferred language, gender, ethnicity, county of residence, home and mailing address, and primary phone number. So healthcare certification must be completed in order for an application to be granted. So that would be one of the first steps in the process, along with Medi-Cal eligibility. The county social worker will interview the applicant in their own home to determine eligibility, and also based on the regulation, the number of hours that the recipient would be eligible for. So the applicant would then be informed if they're approved or denied and what specific number of hours they would be approved for. So a county social worker interviews the applicant in their home to determine eligibility and need. And based on the information gathered, the social worker will assess the types of services that are needed and the number of hours authorized. There's a basic flow of process where once an application is provided to the social worker, the healthcare certification form is mailed out to the applicant. The social worker conducts the home visit and establishes the hours. There's a number of services that IHSS can cover. So some common activities that IHSS can help with are things like cooking, grocery shopping, meal prep and cleanup, medical appointment accompaniment, spoon feeding, helping with breathing equipment, toiling or incontinence related needs, bathing and hygiene, dressing, medication management, tooth, nail, and hair care. There are some additional one-time services that can be approved depending on the specifics of the circumstance. So deep cleaning can be approved on a one-time basis to remove hazardous debris or dirt in the home. And yard hazard abatement can also be approved on a one-time basis. So if there's things like high grass or weeds or rubbish that are posing a fire hazard, removal of ice, snow, or hazardous substances from entrances and essential walkways, things like that. IHSS for a limited time can also approve teaching and demonstration. So that would be to teach skills for the recipient to be able to, administer medications and things like that. So some of the things that IHSS does not cover are things like moving furniture, paying bills, reading mail, caring for pets, gardening, repair services, social outings, and sitting to visit or watch TV. So although those may be needed services, those are not within the scope of IHSS services. So if approved, then the recipient would hire the person to be their provider. So the recipient is the employer. And the recipient is responsible to train, hire, supervise, and if necessary, terminate the individual from services. So as far as some maximum number of hours, there are different IHSS programs, which are essentially different funding streams to support the program. So depending on the specifics of the circumstances, regulations prescribe what maximum hours would include. Public authority is an entity separate from the IHSS division, which helps to recruit and screen independent providers. So it's a resource for recipients who need assistance to find somebody to be a provider. They maintain a registry of providers, refer providers to IHSS consumers. They train and educate IHSS providers and provide support services. So some additional resources are included on this slide for contact.
All right. Thank you,
And thanks
Alice.
for the listening to HSS Nutshell.
Thank you for that presentation on the IHSS. So that wraps up our webinar. We have part 8, Growing Together, Family, Maternal, and Child Health Programs Overview. That's coming up on June 16th, 2025 at 9 a.m. So this one will be a little bit earlier. Hope you can make it if you're interested. And we're going to have presentations from Contra Costa Health, Family, Maternal, and Child Health, the Women, Infant, and Children's Group, and also Black Infant Health. And that'll wrap it up for the webinar. Just a reminder, any of the Q&A, if it hasn't been answered, I'll make sure that gets answered offline, and that'll be included with the recordings, the slide deck, when we get those posted in the future, and I'll mail out a notice to everyone when those are available. All right, thank you. Have a good day.